Okay, good morning everyone. Thank you for coming along to the Student Prize Award presentations. So we've got 3 presentations today. We're going to go in reverse order in terms of the prizes that were won because Miriam's online and we're going to let Miriam go first. So there'll be 10 minutes from the 3rd place student, 10 minutes for the 2nd place student and 30 minutes for the 1st place student. Now, the prizes were won a little while ago, and part of the prize is to present today. So thank you all very much for coming along to listen. We had 56 entries to the competition from more than 20 countries, very close competition, and the winners are here today. So that's great, apart from Miriam, who's online. So we're going to just start with Miriam's presentation. We're going to have questions afterwards. But if you want to ask Miriam a question, you're going to have to come and use one of the microphones so she can hear you, okay? So we'll let Miriam go, and fingers crossed this will work well. So thank you, Miriam, when you're ready.
Thank you. Good morning to everyone. First of all, I would like to apologize for not being able to be there with you today. But thank you at least that I could present it online. I would like also to thank iHEA for choosing my paper. And I would like to congratulate to the other winners since I didn't have the chance to do it personally. And I will start with my presentation, which is related with the incorporation of active impact analysis in the implementation of complex interventions and how we applied it to a study of an integrated intervention for multimorbid patients in the Basque Country in Spain. So this is the outline I will follow. I will start with a brief introduction of how the integrated intervention for multimorbid patients was held in the Basque Country. I will present the evaluation framework we used. Then I will go with the conceptual model in the case study. I will present you some results and I will discuss them. So the increasing prevalence of chronic diseases has led to a profound change in the paradigm of healthcare organizations. Healthcare organizations previously aimed mainly at treating acute problems are not focused on a continuum of care approach. And this implies the integration of different levels of care. In the Basque Country, they managed this by two strategies. On the one hand, a stratification strategy was held to identify those patients that were in need of patients in high needs. And on the other hand, they included new services and roles as the advanced skilled nurse, the reference internist, and the liaison nurse. The hypothesis that goes behind all this is that the empowerment of primary care will lead to fewer emergencies and hospitalizations. It's broadly accepted that randomized controlled trials are the gold standard to determine the efficacy of alternative interventions. However, this is impracticable in complex interventions that require behavioral changes. On the one hand, because they are very expensive, but also because they need to be assessed in the daily routine. In this sense, we propose to use administrative databases. But moreover, organizations are dynamic and these integrated interventions that are complex interventions are difficult to implement. So it's difficult to find a steady state in which the intervention can be evaluated. This is why we propose to use systematic evaluations to analyze trends. So with all this, the objective of the work was to apply the budget impact analysis adapted to local scenarios to develop a tool within the Deming's continuous improvement cycle to manage these integrated interventions. And this is the evaluation framework we propose. In the first stage, in the plan stage, we propose to carry out a budget impact analysis which to estimate the burden of the disease under the conventional scenario and to explore how this would change if organizationally set objectives are achieved. This gives us, on the one hand, a long-term perspective. It would also help us estimate the burden of diseases which are subjected to the aging population, which is an important objective itself. And last, it will let us estimate the impact of the intervention with the objective we set in economical terms. So after this and planning all this, we deployed the intervention, and in the statistical and in the check stage, we proposed to carry out a statistical analysis to determine whether there were resource consumption differences between the conventional and the intervention scenarios. However, the statistical analysis it doesn't always give a broad perspective, because the statistical significance is not always the same as the practical significance. So we propose to compare the real costs in the following years with the cost that we would have incurred if nothing was done, and the cost that we would have incurred if the objective were achieved. After all this, we analyze whether the trends are positive or not, and if the trends are positive, that integrated scenario becomes the new standard, and we continue to work in the same line. And if not, we need to take action and recover the situation. This is the conceptual model we used for the integrated care for multimorbid in the Basque Country. We considered as multimorbid patients those patients that were subjected to at least two conditions between diabetes, heart failures, and COPD, had a hospitalization in the previous year, and the risk scores in the ranges showed there. We considered 2012 as the baseline scenario, and from that moment onwards, the intervened scenario. We identified 1,000 multimorbid patients in 2012 from a population of around 300,000 inhabitants. And we considered as outcomes the resource consumption rates, both in primary care and in hospital care. And we also considered, of course, pulse as the ultimate outcome. We built up a discrete event simulation model to calculate the budget impact analysis. And in this simulation, or in this pathway I showed you, we represent the natural history of the multimorbid patients that we consider it into stages. In the first stages, when the patient was stabilized, they stayed at home and they were cared for by primary care professionals. And only when they decompensated and require additional attentions, they were referred to secondary care. Of course, as they have a really complex condition, they can die anytime. I would like to also to point out that this model is a dynamic model, which means that it considers both mortality and also the inclusion of new cohort patients each year. We populate this simulation model using administrative databases, and in order to represent the intervened scenario, we based our study in a randomized controlled trial carried out by Bernabe and colleagues, in which they determined that an integrated care program could lead to a reduction in emergencies of 30%. We considered these too ambitious, so we set organizationally another objective that was to reduce emergencies by 2% annually, with the goal of reducing it by 10% in a 5 years horizon. And this is the budget impact analysis that we obtained. The continuous line represents how the burden of the disease will increase under the traditional healthcare, and this continuous line represents how this burden would change if we achieve the organizationally set objectives. So we followed, we already did the budget impact analysis in the plan stage. We deployed the intervention, and it's time to do the statistical analysis. It's not the scope of this presentation today. I would just say that Yes. Yes. Can you hear me? Yes. So I'm back. Okay. So as I said, the statistical analysis is not the scope of this presentation. So I would just say that we didn't find the statistical differences between the conventional and integrated scenario. And now I will show you how the real costs were in 2014 compared to the traditional health, to the cost that we would have incurred under the traditional healthcare and under the objective scenario. As we see, the costs were a bit less than what we would have incurred if no action was taken, but still we were far from the objective we set. And to finish, I would like to say that complex interventions are pharmacological interventions because they are formed by various components that follow a non-linear behavior and are difficult to implement. So that we cannot treat them the same as we treat the drugs in terms of evaluation. I would also like to note that scientific conclusions and business policy decisions should not be based only on a statistical significance, because statistical significance is not always the same as practical relevance. And last, I would like to say that backstreet impact analysis provides understanding of the economic burden of the disease, help us explore the potential impact of the implementation, and also help us analyze trends. And this is all from my side.
We're going to try and push the technology as far as we can and ask Miriam some questions. Has anyone got any questions? Or maybe not ask any. Could you come and use one of the microphones? Thank you very much. Can you hear okay, Miriam?
Yes.
Yeah, you did have me worried a minute ago when you disappeared, but...
Yes, I cannot see you, but still I can hear you, so worth enough.
Hello, Miriam. Can you hear me?
Hi. Yes.
My name is Ivan. I'm from Brazil. I work for the Ministry of Health. First of all, congrats for your wonderful work, your wonderful presentation. My question is about the uncertainty. Have you done any sensitivity analysis with the most important estimates, like the reduction in emergency rates? Have you had any issues with that?
No, so far we didn't do any sensitivity analysis, but because it was a preliminary work, we in this case study, we wanted just to test the utility of incorporating the backstreet impact analysis. But you're right, we at least needed, we will need to carry out some sensitivity analysis or get some confidence intervals for the backstreet impact analysis to know how we are, because it could be that if we don't have good data, we could have a lot of uncertainty, and then it's not that useful.
Okay, thanks. Once again, congrats.
Okay, any further questions?
Thank you.
I had one question, which was, have you fed this back to decision makers yet? And if you have, or if you haven't, what would the main message be that you would give about the work that you've done and how it could change things?
First of all, I will tell them that sometimes we evaluate interventions too early in time when they are not sufficiently implemented, and that can be a demotivating factor for professionals, so that at least when they say or when they evaluate the intervention, they need to keep this long-term perspective before determining. And also I would highlight the importance of analyzing process indicators which tell us or give us some insight on whether the intervention is being deployed or not. Also, it's important to carry out subgroup analysis to see whether there are differences in one subgroup and another, and it's being implemented in one subgroup, or just it haven't been implemented at all. So that analysis will help us just give a broader perspective and not only determine whether the intervention is effective or not in terms of poor effectiveness measures like hospitalizations, because we could be mistaken and say that it's not effective when in reality it haven't been implemented sufficiently.
Miriam, for doing this.
Thank you very much for everyone.
So thank you, and I'd like to invite up Theil, who won second prize in the student paper competition, and who'll also present for 10 minutes and we'll have some questions. So thank you.
No, not yet. Okay, so, well, thanks again for coming here, and also tough competition of other presentations here. And also thanks again for the prize, great honor. And thanks Miriam, and congratulations also to her. Yeah, it's a shame we couldn't meet here. Okay, so I'm going to present work together with my co-authors and former PhD supervisors, Marc Surke, Peter Sarnes, and Max Bachmann. And we looked at the relationship between diabetes or diabetes diagnosis, employment status, and behavioral risk factors. So to see, is there, first, does diabetes diagnosis have any effects on employment chances, and how might it be related to how people change their risk behaviors for diabetes complications after they get diagnosed? And to do that, we use two principal identification strategies, margin structural models and fixed effects, and apply that to Chinese panel data. So, I mean, the first, okay, it doesn't work. Sorry. Okay, no. So the first slide, just to refresh a bit the memory of what happened in terms of diabetes prevalence over the last 30 years. So this is from the NCD risk factor collaboration. And at the top, we see the prevalence rates, or the visualization of prevalence rates in the 1980s, and basically the darker the bluish it is, the lower the rates, close to 0 to 5% maybe, in many low and middle income countries, also in particular also in Asia. And then when we switch to 2014, which is at the bottom here, we can see that this has partly inverted, so now many low and middle income countries have much higher rates of diabetes than high income countries. And for example, for China, now has the biggest diabetes population worldwide, as far as I'm aware, of close to 100 million, or around 100 million people, and a prevalence rate of about 10% of its population. And together with that, obviously, comes also not only health effects, but also an economic burden. And we wanted to look at how does diabetes affect employment probabilities there, because there's, for the entire, for many low-middle income countries, there isn't really a lot of evidence on that. There are cost of illness studies, but not really looking at productivity outcomes or employment, and also obviously the behavioral risk factors, because of the potential interplay between behavior change after diagnosis, then how does that affect complications, which then obviously could have an effect on how my employment status changes because of my diabetes, because I may be able to delay or prevent some of the complications. So, yeah, as I said, we provide more evidence on that, and we use these two approaches, which are kind of complementary. with one is mainly being used in epidemiology with the marginal structural model, and the other one is more well known in economics, the fixed effects model. So I'm going to just quickly talk a bit more about how the marginal structural model works, which allows to account for a bidirectional relationship over time, so changes in time-varying variables, how do they affect our outcomes, and how could they bias the estimates. Because, for example, selection to diabetes diagnosis could be dependent on one's employment status. Maybe you become employed, you get better access to care, and you are more likely to be diagnosed, or you change your lifestyle after because you have a higher income. Similarly, for behavioral risk factors, we want to know how does diabetes diagnosis affect my BMI or changes in BMI. Obviously, BMI is also a big factor of predicting diabetes. So the marginal structural model deals with that by the use of inverse probability of treatment weights, where you predict the onset of diabetes or the diabetes diagnosis. And when you weight a regression model to these weights, they count for the individual's entire report history of diabetes risk factors. And then the second approach, which I guess better known here, is the fixed effects model to count for any time-invariant unobserved confounding. So again, listed here the strengths and weaknesses mainly of those two approaches. So the marginal structural model accounts for this, can account for the dynamic relationship, but it assumes that there's no unmeasured confounding of time-variant or time-invariant variables. On the other hand, the fixed effects model accounts for unobserved time-invariant confounding, but ignores kind of this selection to a diabetes diagnosis or the bidirectional relationship between our outcome of interest and the treatment. And we apply these two models to the China Health and Nutrition Survey, panel data survey, which has information on self-reported diabetes from 1997 to 2011. Also provides anthropometric measurements of BMI and waist circumference. And the outcomes we look at are employment status, alcohol consumption, smoking status, and the measured BMI and waist circumference, and also an estimate of the calorie consumption that's constructed in the survey, and controlled for an array of different control variables. It differs a little bit between the fixed effects model and the marginal structural model. So the fixed effects model, I don't include controls for BMI, things like that could be affected by or could have caused selection to diabetes diagnosis. Okay, some descriptors. So I'm just going to focus here on the outcomes that we look at. We mainly see that people with diabetes have a low employment rate, both males and females, drink less alcohol and also consume less calories, and have a higher BMI and waist circumference, what one would expect. Generally, there are low smoking alcohol consumption levels for women. So I'm going to present here the main results. Basically, we also looked at results over time, but I'm skipping that due to the time. So what we estimate here, in total we estimate 3 models. We also estimate a random effects model. And first to look at employment. So we have the marginal structural model, the results here, the fixed effects results, and the random effects results for both males and females. And what we basically can see is that there's no significant employment effect for males. So they don't seem to be affected that much by diabetes diagnosis, while there's a strong effect for women of, depending on the model, the coefficients are quite similar, 11.2 and 11.7 percentage points, which translates into about a 16% reduction in employment chances. And the random effects model kind of supports that, potentially overestimates a little bit the negative effect for employment for females. And then just showing the results here for basically our weight measurements for BMI, waist circumference, and the calories that were consumed. And they basically show that men are able to affect basically these outcomes, or that for men, these outcomes are reduced or positively affected after the diabetes diagnosis. So BMI is reduced, we find lower waist circumference and lower calorie consumption in both models, the marginal structure model and the fixed effects model. And for females, we find generally lower effect sizes, and also in the marginal structure model specifically, no statistically significant effects. And the random effects model basically shows that it's important, especially when you look at BMI and its weight outcomes to count for potential selection. And then finally, I'm just showing the results for smoking and alcohol, which are for females, because they have so low rates. I don't know how important they are, but for males, they basically show also similar pattern that they reduce the smoking, or the probability to smoke, and the alcohol consumption. Okay. So to the conclusion, the results show that the diabetes diagnosis increase the risk of unemployment for women, but they do not do the same for men. But on the other hand, men achieve greater positive changes in their risk behaviors or risk factors, which could potentially explain, at least partly, why we see such differences in the employment effects. I mean, there might be other issues there, and we don't estimate, or we are not able to tell from our results here if that's really the case, but it at least looks partly like that. And the results are robust to the use of different of these two identification strategies, and obviously there would be then a need to see why are there such gender differences between men and women in affecting these outcomes. And I mean, one of the conclusions could be that, for example, if you think about the large undiagnosed population with diabetes in China, that maybe just diagnosing people may further increase potentially inequities between men and women, if they only so if men maybe have better access to treatment and therefore are able to change these risk behaviors better because they have better access to medication or information on how to treat the diabetes, but women are not, then one would have to think about how to change that and also achieve similar changes for women. So that's it. Thank you.
Okay, thank you. We've got time for questions. Yes, please. Could you come and use the microphone when you ask your question, because it's being live streamed around the world, but don't let that put you off.
Thank you very much. Benjamin Yip from Hong Kong. I wonder, the survey, is this a longitudinal survey, so you can actually track the people by time? From your study, once the diagnostic of the women, how long does it take for them to lose the job from the onset of diagnostic of diabetes till the
we haven't looked at that really. What we can see is basically, well, we looked at it over time actually, and what we see that the effect appears quite. So we have some information. So we calculate basically the time since diagnosis, right, since they're first reported, and we see that the employment effects appears quite early, and is then consistent kind of over time. So it doesn't go back up that much at the end. I mean, the standard errors get bigger, but the coefficient is still negative. So it appears to be like a consistent effect, and which appears quite early, actually. So, I mean, one could say maybe women are diagnosed quite late, where the diabetes is pretty much, very much developed, and then these effects appear, you know, maybe earlier than in men. If they, for many, don't find any effects over time. So, yeah.
Okay, thank you.
Hi there. Congratulations on the award again. It's to follow up on that question, really. It's about, I'm wondering whether you had information in your data set around whether the males were the main income earner in the household. So actually the option or the choice of them giving up work to make lifestyle changes just wasn't a realistic one economically for the household, and whether you had that information in the data set to provide further explanation to your finding.
didn't understand completely. So in terms of how much, if they're in higher income areas, or
so you found a gender effect whereby after diagnosis, the females increase their risk of unemployment, or they. And I guess what I'm thinking is thinking intuitively around the reasons why women left work.
Yeah.
And I don't know what the context is, but I'm just wondering within your data set if you had information around who in the household was the main income earner, and whether actually it might be males more than females, and therefore that could be another explanation why you found that effect.
I think so. I think specifically, that is part of the effect, or part of the reason. I haven't looked at it specifically who's the main income earner. I haven't done that. We see that men come from higher income households, or the have higher income than women. So yeah, it would make sense maybe to try to keep on working and earn that higher income, and for women maybe to stop or go into household work. Yeah.
Okay, thank you. I think we've got time for one more question.
Well, this is just pursuing that further, and this may be silly. And I lived in China like 30 years ago, and my recollection is that, I don't know if it's still true, the retirement age was different for men and women. I don't know if that's...
I mean, we looked at the population, would be considered working age population, but I'm not quite sure. It's actually a good point.
If the women were just, you know, if the two populations were the same age, and maybe the women are just retired, you know.
Yeah.
Anyway, I don't know.
Could be. I mean, that's a good point. Actually, I have to check that. Yeah. I don't know.
Okay. Oh, go on. One more quick question. We've got time.
Caroline Watts, University of Sydney. I was just wondering if you saw a blip for gestational diabetes, or those women were excluded or included?
Yeah, they were excluded. So we excluded, we excluded pregnant women. Yeah, we cannot really say if they have gestational diabetes. There's not that information, but we tried to exclude pregnant women because obviously they're also potentially not working. Yeah.
Okay. Thank you very much, Theil.
Thank you.
Now, final paper is by Raf. It's a joint paper by Raf and Tobias, but Tobias isn't going to present today. Raf is, so thank you very much. This is our prize-winning paper, first prize.
Okay, so also from my part, thank you all for being here. And I definitely also want to extend my thanks, or our thanks, to the organization and to the Student Prize Committee for reading all the papers and then choosing ours, I think. First of all, the paper is joint work together with Tobias Müller, who's also here in the room. He wisely chose the center of the room to sit in. And also, it's joint work with Johan Bosmans, who's a cardiologist at the University of Antwerp, and he provided us with the data and obviously quite a bit of advice from the practitioner point of view. As you can see, the paper is entitled, "Does my high blood pressure improve your survival?" And we'll find out along the way. And it's about overall and subgroup learning curves in health. So the general topic will be on learning for physicians or teams or providers or something like that. I think the basic intuition behind our paper is quite simple, but let me first go into the literature just to give some more background to what we'll be talking about, and we'll find out in the next slide. In the literature, there have been three types of effects that have been identified related to learning. The first is learning from cumulative experience, and that's what you would typically think of as learning in a healthcare context. What this says is that for a physician or a team provider, for each additional patient that is treated, you'd expect that the health outcome would improve. So thinking about mortality, if you're a physician, each additional patient that you treat, the probability of mortality will go down, or that's what you would expect. Second type of learning is learning from recent experience, or you could also frame it as human capital depreciation. And this just refers to the fact that the longer it has been since a last procedure, it's likely that the health outcome will get worse. So that's the second type of learning about. The third type is economies of scale, and just says the larger healthcare providers are expected to do better. Why? Because they have better equipment, maybe better standardized procedures, so different reasons why they might do better. But these are things that have been identified in the literature. What we are going to look at is we're going to take it down a notch, and we're going to look at which subgroup characteristics drive these types of learning. So, as we say, these separate overall, so overall for all patients, learning effects may well be driven by certain patient subgroups, and the motivation behind this is that treating more risky patients might improve knowledge and experience more than, for example, treating more low-risk patients. And what we're going to look at is which patient subgroups underlie the overall learning curve. If you would frame it, or if you would look at cumulative learning, then first we had overall, for each additional patient that you treat, you're expected to become better, and that's the probability of a positive health outcome will improve. But in this analysis, we're going to look at if you treat an additional patient with diabetes, are you going to do better? If you treat an additional patient with high blood pressure, are you going to do better? And these kind of things, so we could say what exact subgroups or what exact characteristics drive the learning effect. So that's what we aim to do. I think this is very important from a policy perspective, because we answer the question which subgroups influence overall outcomes rather than looking for which groups' volumes are important. So, for example, what's been done in the literature mainly is you look, for example, at a group of patients, say geriatric patients, and you look whether volume is important for the health outcomes of these patients. If this is the case, then, well, you would conclude if volume is important, we find, well, let's just shut off or shut the low volume providers or consolidate them, and that's about it, which might be a valid conclusion. But what we do is we provide some sort of intuition in between these lines, because we say, well, first look at which subgroups that drive these characteristics. If you can single out the subgroups, then look what you did different in these patients, and then high volume providers can transfer knowledge more easily to low volume providers or new providers to improve their outcomes. And if they then still don't improve their outcomes, then you might conclude, well, maybe better shut them down. But it's some sort of an in-between conclusion that we look for. Okay, then we work with a certain and specific application, which is called transcatheter aorta valve implantation, and this will be the last time that I will say it in full. In short, it's TAVI, and we observe for these procedures all patients that have been treated in Belgium since the beginning that the procedure was introduced in the market. So this generates a sample of 860 patients between 2007 and 2012 in about 23 hospitals. There has been descriptive learning evidence for this kind of procedure, so it has been shown that there is learning in terms of mortality, procedural outcomes, but this has been very descriptive, and what we bring to the literature is a different type of learning and also a more detailed econometric and statistic analysis. So let us have a first look at the data. Here I show you first some graphical evidence on the different types of learning. So we have 4 health outcomes that we look at. First here, 24-month survival. Then we have 3 adverse events, which you wouldn't want to see happening actually. So this is a pacemaker implantation during the procedure, a stroke during the procedure, and a renal failure during the procedure. And on the y-axis, we have the probability of the event happening, while on the x-axis, we have the patient number. So what you see here in the left upper graph, you see indeed that there is a slight positive effect, meaning that for each additional patient that's treated, the probability of 2-year survival slightly increases. We also find this for the pacemaker implantation, although that sounds very bad. We have a perfect motivation behind this, but let's not go too much into detail on that. But you could find it in the paper if you're interested. In the bottom two graphs, we don't see too much, so I don't think we can conclude too much about this. Second type of learning is the human capital depreciation. Again, probability of the event on the y-axis, while on the x-axis we now have the days since the last procedure. So what we find is that indeed the upper two graphs are a bit diverging between the linear and quadratic trends. We do not want to say too much about these, but here on the bottom two graphs you clearly see some sort of effect. So you see indeed with the more days between or since the last procedure, the probability of a renal failure and a stroke goes up in a very slight way. So what seems to be the case as descriptive evidence that different types of learning apply to different outcomes. For survival, we find that the cumulative experience is important, but for the adverse event, we see that this human capital depreciation is more relevant. So that's as a preliminary conclusion. Then, how are we going to tackle this econometrically? First, we're going to look at the overall learning curve without looking at the subgroups. And then we see we're going to estimate linear probability models, and we regress the outcome, one of the four outcomes, on static volume, which is the number of patients in a certain facility in a given year, on cumulative volume, which is actually just a patient number for each hospital. First patient in a hospital, you get number 1, 30th patient, you get number 30. Then also, third variable, time since last procedure, so the number of days since the last procedure. We correct for a number of background characteristics and also hospital fixed effects. When we're going to supplement this with the subgroup learning, what we're really interested in, what we're going to add is in the last regression, we're going to add experience variables for all subgroup characteristics. So instead of only using the patient number, we're going to add patient numbers for every characteristic. So suppose you're the 30th patient in a hospital, you get patient number 30, but then you are the 15th with diabetes, so you get patient number diabetes 15, which would allow you to conclude something about for every additional patient with diabetes that I treat, the higher or the better the health outcome or the worse the health outcome, that's what we're gonna see. However, you could see me coming from far, I think. What's gonna be the main problem with this? This might probably induce some multicollinearity, because if you treat more patients, you treat more patients with diabetes, you treat more patients with high blood pressure, so these variables will look very much alike, and we won't find anything significant, and that's actually what we're going to see. Then there's two ways out, according to us, out of this multicollinearity problem. First is use variable selection methods. Everyone knows if you have two variables that are highly collinear with each other and nothing is significant, you throw one out and the other one gets the significance of both variables. It's not a good approach, but it's one way out. So that's also what we're going to do in a more nuanced context, I think. Second way out is to augment your information in the data set. So you could add extra data, that's not what we're going to do, or you could add information that you obtain from somewhere else. So what we're going to do is we're going to add in a constraint, and this constraint gives more information. By giving more information, you might be able to disentangle the effects in a better way. So that's the two approaches we're going to take. For the variable selection method, we chose to apply the Lasso in this context. As most of you will probably know, the Lasso also minimizes the sum of squared errors, but it adds in a constraint on the sum of absolute values of the coefficients. The technical details don't matter that much, but what it does, it puts a lot of coefficients to 0, and in that way you select the most significant variables out of your model, and you might select the ones that, you select the most significant ones. If you end up with some experience variables, you could transfer knowledge between providers. So that's the basic idea. We also extend to elastic net regression in the paper, but I won't discuss that here. It's actually a hybrid between Lasso and rich regression, but the results are not so compelling, I think. Then the second way we're gonna add information is by doing a Theil-Goldberger mixed estimation method. I've told you what can we do. We can add in a constraint in our regression. Well, we have a constraint to add in, but so you could just do constraint regression, but here we are not perfectly sure of our constraint. If you're not perfectly sure of your constraint, you cannot do constraint regression. The way to go forward then is by using this method, and I will explain this a bit more in a minute. First, let me say what constraint we use and how we will implement this. So first, consider a consistent estimate of the learning curve in the first line. So what we do is we regress survival on the patient number, which is the cumulative experience, and background characteristics. Here I've only put one. So the beta 1 is a consistent estimate of the learning curve. It says for each additional patient that's treated, the health outcome will improve by beta 1. Now, the regressions that we're going to do are of this form. We regress the survival on the same things, the patient number and a background characteristic, but also with an experience of the characteristic. So, for example, blood pressure or diabetes, and we'll encounter these later on. Now, intuitively, it's clear that these subgroup effects should sum to actually the just learning effect, the beta 1 here. Now, if we think in this equation, what should be similar to the beta 1? The beta 1 was, if you treat an extra patient, how much is the health outcome going to improve? Look at the second equation. First thing is, it's the gamma 1, because in this equation as well, it's for each additional patient that's treated, the health outcome will improve by gamma 1. But on top of that, it might also improve with part of gamma 3. So suppose we talk about blood pressure and only 1 in 3 patients has high blood pressure, then if you treat an additional patient, you have a 1 in 3 chance of also increasing the health outcome with gamma 3. So our constraint will be that gamma 1 plus gamma 3 times the average of the characteristic will add up to the beta 1. But of course we estimated the beta 1, and because we estimated it, we're not sure of our constraint, so therefore we cannot do constraint regression. We have to approach it in this way I suggested here. I know it's a bit of matrix algebra or matrix notation. I'm not going to go into it. I'm just going to give you the intuition behind the method. What do you do in practice? You have your real data set as a matrix. You add an additional line in which you put a constraint also with the uncertainty around the constraint. What you then do is you apply GLS to the entire data set, so your real data plus the constraint that you added in, and with GLS you efficiently weigh the information in the two data sets. So actually you get information from your real data but also from the constraint. If we then turn to the results, first, we're going to look at survival, and here, indeed, as we also saw in the descriptive graph, well, let's just look at the columns 3. The other ones are also described in the paper, but these are most clear here, I think. Here, for survival, patient number shows up to be significant. And the point estimate just says, well, for each additional patient that's treated, we expect the probability of survival to increase with 0.16%. So we indeed find that the cumulative learning matters for survival. If we turn to the adverse events, what we see is for these characteristics, we see that the time since the last procedure, so the human capital depreciation, seems to matter. For each additional day between procedures, the probability of renal failure will increase by 0.1%, and the probability for stroke by 0.07. These are small, but if you look at the total patient samples, these grow large quite fast. Then, also very interesting is the 0 days since last procedure. What we saw is, in a lot of cases, 2 patients are treated on the same day. So the second patient has 0 days since the last procedure, and for this second patient, we see that the probability for a stroke is significantly higher with 4 percentage points. Well, we thought, might this be a selection effect? We went back to the cardiologist and we asked, well, if you schedule 2 patients in a day, would you schedule the worst one first or the the worst one second. And he said, if anything at all, we'd schedule the harder one first. But he thought there would probably not be too much selection going on. But then this is indeed maybe a sign of the loss of concentration during procedures. So, but that's very carefully. I stated quite hard, but you should interpret it a bit more carefully, I think. When we now extend this, this overall results with the subgroup results, we added in all experience characteristics, and then obviously what you see is almost nothing is significant here, and that's not surprising at all. We only see one characteristic to show up significantly, and well, actually we're nothing with that because we don't know what's going to happen, or we don't know how we can transfer knowledge from high volume to low volume providers. So then the only way we can deal with this is to go into our methods that we proposed, the Lasso and Theil-Goldberger. What we do is we run OLS on the Lasso and elastic net singled out coefficients. This is suggested to reduce the bias in the coefficients. So we select a set with the methods, but then we run OLS on these selected variables. And then we single out several characteristics. It's too much to name it up all the time, but I'll give you the main intuition later on. So we single out 3 characteristics, which is already better than 1, but you see the one of last time is not in this set, which is quite unfortunate because that doesn't seem to be too robust, but it's also what you could expect maybe from the Lasso because you throw out a lot of other variables. The elastic net is just a hybrid between the Lasso and Ridge, and what it does, it just gives you more significant results because it singles out more coefficients, or it singles out at least more coefficients. And again, what we see when we do the logistic Lasso, results again don't correspond with each other, and again we single out some new variables and we don't find other variables to pop up to be significant. However, what you see is the experience with core valve stays in the set all the time. And this is actually a nice story to tell, and that's also what the cardiologist, I think, took away from a lot of the analyses. With these heart valve replacements, there's two types of valves that are used in practice. Core valve valves and Sapiens valves, so 2 types of brands. And each brand is uniquely used in each hospital. So one hospital chooses one brand and keeps itself to that brand. So what actually this coefficient shows us is that the learning effect is different across the 2 types of valves. So we see that for the core valve valves, the learning effect is a bit higher than for the other brand. Now, where could this come from? These brands all have a system of clinical proctoring. So what they do is, for a new procedure, they choose some physicians that are experienced with the procedure, and they let these physicians help new physicians or physicians that are not experienced with the treatment, help them set up in the first place. And for this core valve, the system of clinical proctoring is a bit better or a bit more extensive than for the other valve, for the other brand. So that might be an intuitive effect that we at least find here. Then, a lot of coefficients going on here, but I'll just give you the basic intuition. What did we do? We did 4 types of estimations. First, we just showed the results of the OLS, then GLS, so robust OLS, because we have to account for the fact that we do linear probability models and the errors are heteroscedastic. Then GLS to get the minimum bias estimator, so the lowest, the most efficient estimator, I mean. Then we have robust OLS added in with the constraint in the 3rd column, and then GLS added in with the constraint in the last column. So actually what's important to compare is the 1st and the 3rd column, and then the 2nd and the 4th column. So when we move from robust OLS to when we add in the constraint, actually what we see is that not a lot goes on. So actually our added constraint doesn't add anything to our analysis, and too bad we don't find any more intuition behind it. However, when we apply GLS, we already see, just by applying GLS, that we find some more significant variables. So here, this is more significant than we find a variable here. So at least this already improves our analysis, because we look for the lowest variance estimate. But then when we transfer to the last column and we add in the constraint, then we see that the significance increases a lot between these estimations. So we single out more subgroup characteristics that we could think of that can contribute to improving health outcomes. So in this analysis, we single out these and these and these more compared to when we don't apply the constraint. So we indeed see in some circumstances our way of adding the constraint can help in singling out more characteristics. Then a couple words about the robustness of our results. First of all, the overall effect of cumulative experience is quite robust to leaving out some of the largest providers. So overall, we think that that result is quite robust. However, the results on the human capital depreciation, they're quite sensitive to outliers in the number of days since the last procedure. So we could just, we shouldn't interpret them too harshly, I believe. Third remark, actually, is that with applying this Theil-Goldberger method, non-linearities in the relationships may cause subgroups to be significant even if they are not. Remember, what we do is we just apply linear probability models, and you need them to be able to add in the constraint. But it might be that by adding in all the things linearly, that you catch some of the significant results are due to the non-linearliness in the relationships. So this figure may illustrate some kind of intuition on this. So suppose that the relationship between 2-year mortality or 2-year survival is nonlinear with respect to the patient number, so the cumulative experience. So it might have a tertiary effect or a third-order effect. And then if the patient number is related to one of the experience characteristics in a nonlinear way, then this characteristic might pick up some of the significance because actually the patient number is nonlinear. And that's why you should also interpret it carefully, that not all of the significant results are necessarily significant. And actually that's maybe also with what I want to conclude and what you should take away from today. I don't want to put my hands in the fire for my results, but at least I think that the way we've approached it, you're able to single out some characteristics that might drive performance for providers. When you single out these characteristics, then healthcare providers should scrutinize these results, think about them in a sensible way. Are these characteristics some things that we think we're doing different stuff with? What are we doing different, and how can we transfer this knowledge to other providers? So it's not that we claim to have a perfect analysis, but it can at least serve as information for physicians to transfer knowledge. And I think that should be the takeaway. Also because we find mixed evidence, because between the methods, our Theil-Goldberger and Lasso single out different variables. And I think, therefore, our results should softly be interpreted. Okay, and then I'm open for questions.
Thank you, Raf. Excellent. Okay, questions? Don't make me ask one. Okay, Raf, you said you didn't want to put your hands in the fire and claim anything from your results. But say you had to put your hands in the fire and claim something from your results. Is this generalizable across other procedures and areas? And have you fed it back to anyone yet? And what did they say?
Sorry, the first part, is it generalizable too?
How generalizable do you think this could be in terms of uptake and being a model that could be used elsewhere? And have you fed it back to anyone, and what did they say?
Well, I fed it back to the cardiologist we worked together with, actually. He provided the data, but then also helped us interpret the results. I think the main takeaways for him were the overall learning effects and also this concentration effect that we find when two people are scheduled on the same day. And then also the core valve effect, this experience difference, the learning curve difference between these different types of valves. That was one of his takeaways. For the other ones, he couldn't really interpret it, so I'm not sure whether these results should be, well, at least he didn't know immediately on the spot what to do with them. Then in terms of generalizability, I think that the success of the method is probably really very dependent on the context and on your analysis. It's actually what you see, let me go back. It's what you see here. It's, if we just do the OLS and we add in the constraint, nothing happens. So it all depends on how close the, I think if you're focusing on the significance, I think it's probably how close all variables are to significance to start with. And that's what shows up here. If you do OLS, they're not close to significance to start with. Adding in GLS, we narrow down the variances. By narrowing down the variances, we come closer to significance, and then adding in the constraint, that helps a lot. So I think the answer is two ways. How close are you to significance to begin with? And second, how much information is there in your constraint? We've been playing around with this, but I don't exactly remember the results. But of course, you spread out one result. You say all the coefficients have to add up to this real consistent learning effect, but you actually spread this out over a lot of coefficients. So how much information is there in the constraint? We've played around with this, I remember, but I forgot the exact details about this.
Thank you. Adam?
I'm sure Guillaume will help me. So I might have missed it, but the data are from a group of physicians, is that right? Or one physician?
It's for all hospitals in Belgium, so it's 20 hospitals, and actually there's only one team that really does the procedure in a certain hospital. So you could see it as a team, a physician, or a hospital effect in terms of learning.
So is this the universe of patients with this procedure?
Yes, it is from 2007 until 2012, but you see that, well, in the beginning it was not popular. Well, it was popular, I think, but then it wasn't reimbursed at all in our sample period. So what happened is that when eligible patients came to the hospital had to finance this procedure partly itself. So that's why there's such a small amount of patients. But by now...
But it is the universe.
It is the universe, yes.
So I'm wondering why you're putting so much emphasis on statistical significance when you don't have a sample, you have the universe. The real interest is in the magnitudes of these effects and giving some intuition to that. And my follow-up question was, you have here, in a sense, some hypotheses that you're not able to nail down, perhaps because of the issues you've been talking about, but it lends itself to quite an interest, potentially several, but at least one interesting prospective experiment which would be to persuade a group of physicians to explicitly randomize the order of patients when they have two patients on the same day, and conduct a prospective randomized trial where you wouldn't need to convince them about these complicated econometric methods. You use a technique that they would be familiar with, and you could nail that once and for all.
Well, there were two parts of your question. Let me be sure that I answer them both. Concerning your last point, I'm not, well, about the same day effect, obviously there you would be able to randomize, but I don't think you could randomize in any different way because overall you need it when you need it. But on the same day, I agree, for that effect, it might be interesting to have a look at it, to let some people do it randomly, some don't, not let it do it not let them do it randomly and see what kind of selection plays around in it. That might be an interesting finding in itself, I think. Then regarding your overall comment on the statistics and if we have the universe, why we still attach so much importance to the statistical analyses. I think that's an overall discussion that you're never sure about your results, and that therefore you still, even though you have the universe, there's still part of the full distribution, and you only have limited information about the full distribution. So therefore, I think you're not really sure about everything, but I'm not sure whether this is a good answer to your question, to be honest, but I'll have to think about that further. Sorry.
Okay. Yes, please. Can you use the microphone?
Yes, thank you very much for your nice presentation. I have one question about the severity of the affected patients. So, because as TAVI was introduced, it was used for very severely severe patients. And what I could imagine is that during the following years, the physicians said, oh, we can also use it for less severely affected patients and expand that. And so I'm wondering if you can pick up this effect with your control variables, or if it can be that some of the learning is just because of you treat less severe affected patients.
You're perfectly right, and I think there's different sides of the story to it. First of all, I think, as I just said, throughout the entire period, none of the procedures was reimbursed. So I think there was a clear incentive not to overkill it with the procedures. So, well, still there might be some selection playing, but I guess that might still limit it to some extent. Second, I think we have a quite extensive range of background characteristics, including categorizations in New York Heart Association categories, which might also pick up the severity. So I think that's the main argument in response to your question, but still I agree that something can still be there along that way. So honestly, I think also what we discuss more in the paper is that these experience effects themselves, they might pick up learning, but they might also pick up selection. And you don't know which of the two it is, but that partly explains the negative effect of some of the subgroup effects. Just unfortunately, we cannot split them up. We cannot disentangle whether it's a selection or a learning effect, but actually it's not so important. Because I think if you transfer the knowledge between providers, a provider knows, suppose we here have, I forgot to answer the question in paper, in the title, now I remember, but suppose you have experience with hypertension, and that shows up to be significant. Then you say to a physician, okay, what differed over time in these patients? So their response can be either, well, we started treating them differently, we started giving other medications, but we could also, along the line, we decided to only select those with lower severeness of the hypertension. Although here it's only a binary variable, they could still say, well, he only has minor hypertension, he has... So it might be a selection effect or a learning effect, but that's picked up to some extent by the subgroups. And I think that's also information, and you have to know whether that it can be selection and that it can be an effect, a learning effect, and then you have to scrutinize it as a practitioner, whatever it is.
Okay, thanks, Raf. Dylan? Okay, before I finally thank the students, two things left for me to say. The first is the announcement of this year's student prize will be in a few weeks' time, so get ready. Very exciting, I know. And the second thing is, I know there's several members of the Student Prize Committee here. You were thanked officially and named at the plenary on Saturday, but if you could come down and meet the students afterwards, that would be really nice. So finally, if I could just thank Miriam, who's now watching online, and Theil and Raf and Tobias for their great papers and great presentations. So well done again, congratulations.